Hello everyone, and welcome to today's The Scientist webinar. My name is Nathan Nee, Associate Science Editor for The Scientist, and I will be moderating today's discussion. Today, our speakers, Dr. John Connolly and Dr. Masataka Nishiga, will discuss the effects of SARS-CoV-2 on the neurological and cardiovascular systems, respectively. We like our webinars to be interactive. We encourage you to send us your questions or comments at any point during the webinar, and the speakers will address these during the Q&A session following the presentation. To ask a question, simply click on the Q&A tab and type your query into the question box located on the right side of your screen. We will try to address as many of these as we can during our Q&A session. This webinar will be archived on the Scientist's website, and we will send you the link via email within a couple of days. Please note that you will not be able to download the presentation slides. I would like to take this opportunity to thank our webinar sponsor, Sinobiological. Sinobiological is an international reagent supplier and service provider specializing in recombinant antigen production and antibody development. The company has developed a comprehensive collection of SARS-CoV-2 research tools, which has been cited by over 280 papers published in Cell, Nature, Science, etc. Sinobiological has recently launched recombinant SARS-CoV-2 Y453F MINC mutant, which can be utilized to evaluate the efficacy of antibodies and vaccination. To support influenza research, Sinobiological has developed a panel of recombinant antigens covering most influenza vaccine strains from 2015 to 2021. For more information, please visit www.sinobiological.com. Our sponsor has provided us with some helpful resources related to today's webinar, and we have posted these in our handout section located on the right side of your screen. You can access and download these documents at any time during the webinar. With that, let me introduce our first speaker, Dr. John Connolly. Dr. John Connolly received his PhD from the Institute of Psychiatry, Psychology, and Neuroscience at King's College London, and is currently a professor and Senator William McMaster Chair in Cognitive Neuroscience at McMaster University in Hamilton, Ontario. Connolly is the co-founder and chief science officer at Vox Neuro, a company that commercializes his research and EEG methodologies and makes them clinically available. Connolly is also the director of the Aerial Research Center at McMaster University and is appointed in the faculties of Engineering, Science, Health Sciences, and Humanities. Connolly assesses cognitive function in healthy individuals and those with acquired brain injuries. His work is documented in over 300 peer-reviewed publications and presentations and has been supported by funding agencies across the world for almost 40 years. He actively reviews research for a wide range of journals and funding agencies, is a faculty affiliate at the Vector Institute of Artificial Intelligence, and is a member of Brain Injury Canada's Scientific Advisory Committee. Dr. Connolly, let's just check if everything's in order technologically. And it appears so. So, Dr. Connolly, the floor is yours. Please take it away.
Welcome to all the listeners. So I just want to give you a quick roadmap of where I'll be going with this talk. I'll be talking about initially the acute version of the virus. What I'm particularly interested in these days is the long hauler syndrome. So I'll get to that in the last third of the talk, but initially I'll just go over the actual virus a bit to make sure everybody is on the same page. My understanding is, and I am sure this is a very sophisticated audience, but it still will represent a variety of domains. And by training, I'm a neuroscientist that now specializes in cognition and brain measures. So I'll be concentrating on that in parts of the talk. So this is a slide taken from the Johns Hopkins site about a month ago. And you'll see that the global cases, and again, this is an underestimate. I think everyone knows that the count is significantly higher because many people don't get officially diagnosed, etc. but the global case count in mid-November was 55 million. In the US, it was 11 million. And 1 month later, the count globally is 72 million, and the count in the US is 16 million. So this virus, in its second wave, it would appear to be second wave, is not going anywhere except up, and in some areas exponentially so. So in terms of what should we have expected from COVID-19, so this is a little bit of a history of viruses that I'll be pretty quick with, but nonetheless, in February of 2020, in the American Academy of Neurology journal they send out to neurologists in the US and elsewhere, I'm sure, there was an article entitled COVID-19 Neurologists in Italy to Colleagues in the US. Look out for poorly defined neurologic conditions in patients with the coronavirus. This was the first explicit account that there were poorly defined neurological conditions. I'll get back to that in several minutes, but it was really a warning shot because even earlier, as I'll talk about in a second, there were papers already out of Wuhan, China, in fact, that were talking about neurological consequences to this coronavirus. In March, Dr. Nath at NIH talked about major clinical manifestations of COVID-19 due primarily to pulmonary complications. Not incorrect at that stage, but there was clearly more going on. And in April, as I mentioned, from Wuhan, a paper by Mao and colleagues said that about 50% of those with severe respiratory symptoms also showed cerebrovascular and what they referred to as consciousness symptoms. And between about a third and about 45% had neurological symptoms based on COVID-19 severity. In April, Hermann et al. Talked about an emerging literature suggesting a daunting clinical relationship between COVID-19 and neurological illness, and had some advice for their fellow neurologists around the world, and that was to get ready. In June, a very now well-known study out of the UK talked about psychiatric consequences of the virus. 62% of the sample they tested, 125 people, had cerebrovascular events. 74% had ischemic strokes, and you can read the rest yourself, but I think the 31% had altered mental status, and that was encephalopathy and encephalitis. But it was also, what they were seeing were dementia-like neurocognitive syndromes, and also full-blown psychoses. And at ages that one should not be seeing new onsets of illnesses like that. And in fact, in Italy, returning to Italy, they were the first to open a specifically designated neuro-COVID clinic. And they did that around March or late February at the University of Brescia, just east of Milan. And we had some hypotheses as we were getting ready to do our clinical neurophysiology work in long-haul patients. And that was based on other viruses, because there is a rich literature about other viruses, even if this is a novel coronavirus. So the RSV, or respiratory syncytial virus, is neuroinvasive respiratory agent that's been detected in CSF of patients and is associated with, as you can see, a variety of symptoms, again, including encephalitis. And I think it's worth remembering, as I think I will mention later, is that this can move into much more serious conditions that show a great deal of similarity to multiple sclerosis. Influenza type A has been studied quite a bit, both by University College London and in collaboration with the University of Laval in Quebec. And they've been looking and demonstrating, sometimes in preparations rather than in humans, that encephalitis, some of the symptoms in humans, Ray's syndrome, febrile seizures, acute necrotizing encephalopathy, and again, possibly acute disseminated encephalomyelitis. So that's basically when encephalitis progresses or becomes more aggravated. And in one study that was taken from the experience that they had in Italy, again, and this is taken from the Sapienza group, a Sapienza Medical Center. And they said it reaches the COVID-19 reaches the CNS, and the neurological symptoms in patients, they put into 3 categories. The first one they described as neurological expressions of the illness, or the neurological expressions of the symptoms. And that included headache, dizziness, disturbance of states of consciousness, motor balance issues, ataxia, and stroke. Symptoms, and then the second category was symptoms of neuroperipheral origin, and this would be taste, smell, and then finally the skeletal muscle damage was also observed. And in the human coronavirus OC43, there was a case demonstrated, and it was the first demonstration of a neuropathological effects of this virus in severe respiratory responses, and that was associated with a fatal case of encephalitis. Now, to return to the study out of the UK, out of Liverpool primarily, and it was about neurocognitive symptoms and neuropsychiatric symptoms. And that was this study that talked about 62% showing ischemic stroke, cerebrovascular events and ischemic stroke, as well as intracerebral hemorrhage. And then again, just to drop down to one category that wasn't in the first slide, 43% of that population had new onset psychosis. And then again, 26% showed neurocognitive type syndromes. And 30% they just couldn't classify in ways that they were comfortable with. And this is a slide from that, or a picture from that study. And I think the point they were making here was the interesting age distribution. So younger people up to about the age of 50, they tended to show particular effects, and then again at 70, neuropsychiatric effects. Whereas the older population tended to, there was also always a presence of cerebrovascular disorders, but that seemed to come later, in particular later. The neurocognitive symptoms in COVID-19, paper by Helms, and that was published in April. They talked about the neurological features, as I was saying before, in the New England Journal of Medicine, and they had a sample of 58. Now, they were able to record EEG in only 8 of them, and they noticed only non-specific changes, and 1 in 8. So what they're really saying is a very small percentage showed by a diffuse bifrontal slowing consistent with encephalopathy. So this really doesn't speak well for EEG, although they only did it on 8 of their subjects. But I want to make that point because I think standard clinical EEG is not going to be of enormous value in examining neurocognitive or neurological patients with COVID-19. Here is, again, a figure from this study, and they found that 84%, as you can see in the top right here, I think you might be able to see the mouse here, but I'm just moving around here. So 84% had neurological signs. Elevated temperature was actually surprisingly low in this study in terms of percentage of patients that showed it. I will get back to this confusion assessment method for ICU patients, but 65% of those patients performed poorly on that test. They noticed agitation in about 70% of the patients, and jumping to a cognitive sign, dysexecutive syndrome occurred in 36% of those patients. So in terms of behavioral assessment, which I'll get to in terms of reliability, there were certainly signs of neurological problems with COVID-19, as well as neurocognitive effects, for example, the dysexecutive syndrome. Moving on to the confusion assessment method, and don't worry, this slide is far too complex, but I just wanted to get the complexity of this there and also emphasize what they were asking people to do, because this is meant for the ICU, but it was being used with these COVID-19 patients. some of whom were in the ICU, although we now know that that is a poor predictor in some respects, as is severe respiratory consequences. It's a poor predictor of severity of cognitive and neurological signs. But nonetheless, they were asking people to squeeze my hand when I say the letter A, so requiring a behavioral response of these patients who are suffering from delirium, possibly. So it's a problematic approach to this. Also disorganized thinking, and this is, will a stone float on water? And again, behavioral responses are what are required here. And many of these patients were finding it difficult to make those sorts of responses, let alone patients in the ICU. So this, I think, is problematic using behavioral assessments. And so there's the obvious question I'm asking here, and it's, are they not sufficient? And the answer is unequivocally no. I'm now going to pivot to work that I began in the early 90s, and that's with patients who have been diagnosed as being in a vegetative state. And I'll just take really 2 slides, maybe 1 slide. I'll just cover this topic very quickly. But diagnosis of disorders of consciousness, it really is a story of consistent errors. And that is because it's behaviorally based. So initially, and you can see some of the numbers here, between 36 and 43% of patients diagnosed as suffering from a vegetative state are found to be misdiagnosed. We tested a patient in the early 90s who was diagnosed as being in a vegetative state using what is still in many locations the traditional assessment tool, and that is consensus diagnosis. And that's where these disagreement numbers come from. And we tested this patient using clinical neurophysiological techniques and evoked and event-related potentials, and found that this patient that we saw, again, 30 years ago, that is not the picture of the patient involved here. It's a different patient that I'll get to in a second. And we tested the young man 30 years ago and found that he was not in a vegetative state. In fact, he was exhibiting a wide range of cognitive functions if we looked at evoked potentials and event-related potentials. So that was our first entry into the field, where we finally published that in the late 90s. It did not meet with ready acceptance, but nonetheless, it has been replicated now repeatedly, and a recent study by Caroline Schnack, is formerly in Liège, Belgium, at Stephen Loris's group, found that 41% of a group she tested, looking at vegetative state using traditional consensus, were found to be at least in a minimally conscious state. So the problem with even the test that she used, which is the coronavirus scale, the revised version of it, a very, very good behavioral test, but even a study done by the same group several years later by Juanez demonstrated that it itself was wrong 36% of the time. So really, the only way you can really look at these patients, as in the patient that you see before you, is a man that is well publicized here in Canada. And we tested about 10 years ago, and he was in a vegetative state, diagnosed using the Rancho Los Amigos test, another behavioral test, and found not to be in that state. And in fact, he was not put into palliative care. He went into a rehab program. And you can see the results in the other picture that's in front of you there, where he is learning to walk again, because his cognitive function was almost immediately present in terms of evidenced by the event-related potentials. Several months later, he began speaking, and he had memories of the entire experience of the hospitalization. He is now learning to walk again, and speaks fluently and is quite communicative. So behavioral assessments matter. Now, in terms of why they matter, first of all, they are able to assess and differentiate functional symptoms or functional activities like attention, memory. They can assess change over time. They can assess responses to therapeutic interventions. They can also measure, provide measures that are objective, quantitative, replicable, and clinically relevant. And basically what we're doing in our research is moving past problematic diagnostic issues to direct assessment of the symptoms and basically the cognitive functions underlying those symptoms. And we're also capable to assist in some decisions of rehabilitation targets, which type of dysfunction to go after first and foremost. So in terms of the current thinking about long haul, first of all, it's not uncommon. I read a paper recently, it was a little bit dated, but it talked about 20%. A conservative estimate is 50% of those formally diagnosed with COVID-19 will require formal and extensive rehabilitation. This comes out of the National Institute for Health Research in the United Kingdom, a paper by Elaine Maxwell. She's going to be updating it because, as she said, the 50% was a very conservative estimate from those suffering from the virus. And these are various current theories, let's call it, of the mechanism of the neuroinfection. Some people are just reading something this morning that suggests it's not, COVID-19 is not necessarily primarily neuroinvasive, but there is work, as I said, from UCL and Laval that indicate that it can be. And although the suggestion that the first cranial nerve is involved may now be suspect because of work from the US, it still is entering the blood, the brain, possibly through dysfunctions of the blood-brain barrier, but also the cytokine storms. So immune systems that overreact to COVID may end up producing a much larger dysfunction. And the cognitive effects are involving memory, attention, executive function, and then there are, again, psychological or psychiatric consequences. Ventilation is probably not as much a player. It's a confounder. It's a comorbid, if you like, consequence. But there are certainly patients who have never even been admitted to hospital, and in some cases not formally diagnosed until after the fact, where they're suffering from long haul COVID symptoms, as having acquired COVID, if I can put it that way. That they never had ventilation, so it was not that was not a consequence or a cause, as I should say, a cause of the virus, of the symptoms of the virus. And then it isn't just coronaviruses. So hepatitis C has been looked at and also found to produce cognitive symptoms. And again, neurophysiological measures. This was a study done in Rome several years ago. They found neurological measures of attention and memory were the only measures to show abnormalities, and they exhibited changes, normalized latency, when therapeutic intervention was undertaken. So in terms of, so what are the options for patients today? So at Vox Neuro, which Nathan mentioned, I'm the chief science officer for, we've commercialized this work. And we're using the NeuroVox's platform to provide clinical service today for those struggling with the long haul symptomatology of COVID-19. And we're testing them. And in fact, we're probably one of the groups that's testing the patients on a regular basis with this problem. And what we're doing is we've got some core cognitive functions that we look at as a matter of course, and then we can extend those, but we're looking at automatic attention. For those of you familiar with event-related potentials, this is the mismatched negativity. So we're looking at automatic attention, which is also what some of the responses we see are about auditory processing and information processing. We're also looking at the continuous visual memory test. So it's a test very much used in brain injury. We're seeing memory effects. We're looking at working memory, visual processing, and again, information processing. We're then using a very simple but very effective 3-deviant oddball paradigm. So this is, again, for those familiar with this type of work, what it enables us to do is to look at executive function directly through an N2B waveform, concentration in particular, and also reactive attention, because they have a task to do, and that's to press to a particular deviant stimulus. And in some cases, we also look at the Peabody Picture Vocabulary Test. It's really a vocabulary comprehension test, but it is extremely useful. and used quite a bit by allied health people like speech-language pathologists. And it also can help us look at auditory processing and visual processing. So we've adapted that for simultaneous recording of EEG. Now, patient examples. I think a talk is incomplete if one doesn't show the actual waveforms here. And what you can see in the top row, so the two slides at the top, on the left is a very small group of young COVID long haul patients. And you can see they show very good looking waveforms, and they are commensurate in appearance generally with the right hand side, which is a healthy group of controls, quite a larger group of controls. But these are what it's really showing, if I can just emphasize some points here, that first of all, the latency of the COVID, even the young COVID, is slightly delayed very slightly compared to the young COVID patient, the young controls. But also you can see that aside from the red line, which is one type of deviant, a duration deviant stimulus, you can see that there is no sign of a negative response in the other two deviant categories, where it's quite clear in the healthy controls. The story is much more dramatic in the older cohort. So on the left again is older cohort sufferers and older healthy controls. Here you can see that the older patients show a slight delay compared to the younger healthy people. So the older healthy people show a slightly delayed response, which is in the COVID older people is quite significantly delayed, something we're seeing quite a lot of. And again, you can see that in comparison to the very robust response that's associated with executive function, the N2B, you can see here again that in the elderly COVID sufferers, it is not as robust and not as tightly exhibiting in timing. So there are real problems here with this population, in this older population. And just to emphasize that point, I will just move to the next slide, which is put in this slightly unappealing array, simply to emphasize these are younger COVID people and older COVID people, but not very old. These are middle-aged, some of these people. And what we're seeing here is that even someone who is in her mid-20s and someone in their early 30s, there is a latency difference here. And this is going to be related to other factors determining the severity of the illness. But what you can see is the amplitudes here are really quite small in this person, and they stay small in these three older people. This was the most severely ill long haul patient that we saw. And you can see she's almost showing none of the responses that we see in this person, and we see normally being, in some cases, almost as great as this person is exhibiting. They should be bigger than this, and they're not. So there's really a problem here with memory and with executive function in these patients, especially in this area. You can see it. And this is what I was referring to earlier about the specificity of event-related brain potentials, that they really are, and they have been since the early 60s right up through the mid-90s. They've been associated with very specific cognitive functions. So when you see them present, you know what someone is doing in that experiment, which you've designed to elicit that response. But when you see it in a patient, you know that they are not performing that task successfully, whether they're able to communicate that fact or not. And I think one of the benefits long haul patients are finding is that when we can demonstrate these clinical neurophysiological changes in these patients, that it is a type of response that neurologists and other healthcare professionals can and should rely upon, as opposed to hand squeezes and as tested in the confusion assessment method. And I should add, we're doing not that test, we're testing coma patients, and we find very clear responses in some of those patients, indicating replicating some work that was done in France a while ago, replicating and then extending some of that work in demonstrating who will and who may not emerge from a coma. and then also what state they may be emerging into, be it a locked-in state or a vegetative state or a minimally conscious state. So we're extending a lot of that work. This is a type of assessment sheet that we hand back to physicians. And again, we just look at on the response time. I should add, these are made up. These are approximately correct, but these bear no resemblance to the actual patients we saw. So you're seeing here that the response time in this individual is really quite acceptable. It is the response strength that is a problem. And in particular, it's about reactive attention, concentration, and working memory. And to a lesser extent, but still not good, executive function. And you can see a similar sort of story here. Again, there is some response time abnormalities, especially when it comes to working memory, because this person had a very significant problem with working memory. So it was a very, very delayed response. And again, where you can see that this person is showing a wider range of cognitive functions due to the long haul symptoms that she is experiencing. And again, we can just quickly look at this patient. Again, this person is showing a few more response latency problems and then a number of response strength problems. And the last person here is just showing significant problems at every level of analysis, except for the working memory, oddly enough. It was a weak response strength, but what was there was, it was present. It was just very, very small. But the timing of it was actually very, very traditional. So you can see there are real problems here in most of all of her cognitive functions in terms of the strength or the amplitude of the response. So I think in summary, this is my intent here was to really target neurocognitive symptoms of long haul patients because they are viewed as something that initially, understandably, those in the ICU had more important things to do, and that was to keep people alive. But right now, it's a case of that's still the case, but when they become long haul patients, and when some of these patients are discharged from the ICU and still experiencing symptoms, as some of the patients we saw, they are still showing symptoms 8 months later, and they wax and wane. Another very disturbing sort of sign. They think that some memory aspects are getting back to normal, and then it turns out they hit again. This is something that really needs to be monitored, and that's again what the National Institute of Health Research was talking about when they said conservatively 50% of this population will need really rehabilitation. Okay, I'll stop there. Thank you very much.
Thank you, Dr. Connolly, for that wonderful presentation. And as a reminder to our audience, you may submit your questions to our speakers using the Q&A tab at any time. Our next speaker is Dr. Masataka Nishiga. Dr. Nishiga is a physician-scientist studying cardiovascular diseases. Trained as a cardiologist in his native Japan, he is currently a postdoctoral fellow working with Dr. Joseph Wu at Stanford University to study molecular mechanisms of heart disease using human stem cells. Nishiga earned his MD from the Faculty of Medicine at Kyoto University, and following this, he worked as a clinical cardiologist for 5 years before starting his PhD, also at Kyoto University. During this time, Nishiga studied the molecular mechanisms of atherosclerosis, heart failure, and cardiac fibrosis, focusing on microRNAs and non-coding RNAs. At Stanford, he works on human stem cells for genetic screening of heart diseases using CRISPR technology, cell therapy, and COVID-19. He is currently funded by a fellowship from the Japan Society for the Promotion of Science and as well as the State of California's Tobacco-Related Disease Research Program. Nishiga recently authored a review article in Nature Reviews Cardiology concerning the relationship between cardiovascular disease and COVID-19. Dr. Nishiga, let's just make sure everything is set up properly from a technological standpoint, and everything looks good. Dr. Nishiga, please take it away.
Thank you so much for your kind introduction. Today, I'd like to talk about cardiovascular involvement of COVID-19. Cardiovascular damage is one of the hot topics in COVID-19. For example, the first patient in United States of COVID-19 died from cardiac rupture in California. This is another example. This news is showing that about 30% of college American football players who got COVID-19 were diagnosed as myocarditis. What they are saying here is that even young and healthy patients may have cardiac damage by COVID-19. COVID-19 affects many organs, including lung, heart, brain, eyes, nose, liver, and etc. And the cardiovascular system, which includes heart and vessels, is one of the most affected organs in our body. Clinical studies showed that cardiovascular disease and COVID-19 have bidirectional impact on each other. So first, in this talk, I'd like to talk about how cardiovascular disease affects COVID-19. These are papers from China, in particular from Wuhan, at the early time point of this pandemic. They reported comorbidities of COVID-19. The comorbidities are pre-existing diseases before the patient gets COVID-19. The comorbidities of COVID-19 were mainly cardiovascular disease and its risk factors, such as hypertension and diabetes. This is one example. Among about 200 patients, the top comorbidities were hypertension, diabetes, and coronary heart disease. And the percentages here go up in patients who did not survive. This is another example from CDC of China, about 40,000 patients. The overall mortality in this data is about 2.3%. And again, the top comorbidities of COVID-19 were hypertension, diabetes, and cardiovascular disease. Although the definition of cardiovascular disease here is not very clear, what is striking here is that about more than 10% of patients of COVID-19 died if they had cardiovascular disease. And this number is even higher than any other comorbidities, including lung disease and cancer. And basically similar results were reported from United States or European countries. So what we can say from these results is that somehow patients with cardiovascular diseases are more likely to get severe symptoms, but we still do not know the reason yet. And next, I'd like to talk about how COVID-19 causes cardiovascular disease. Clinical studies showed that COVID-19 causes diverse cardiovascular complications, including myocardial injury, which is the damage of the heart, and heart failure, acute coronary syndrome, including myocardial infarction, and pulmonary embolism, stroke. And it is also reported that children may develop multi-system inflammatory syndrome, which is similar to Kawasaki disease. In this talk, I'd like to focus on myocardial injury, which is the damage of the heart, because this is, as I mentioned, this is one of the hot topics in the media. In terms of myocardial injury, this paper was published from Wuhan at early time point of this pandemic. They reported that about 20% of the patient, 20% of hospitalized patients showed elevation of cardiac troponin I in blood tests. And as you can see here, the mortality of patients who had cardiac injury was about 50%. So about half of the patients died in 1 month. On the other hand, the mortality of patients without cardiac injury was very low. And as you can see here, the mortality of patients goes up depending on the level of cardiac troponin I. In the group of highest troponin I elevation, the mortality was over 90% in this study. The same thing was reported from United States as well. This paper is reported from Mount Sinai, and they showed that about 36% of hospitalized patients had elevation of cardiac troponin I. They divided the patients to 3 groups: patient with normal troponin I group, and the patient with modestly elevated troponin I group, and patient with high troponin I. And the mortality of these groups are 10% in normal group, and 30% in the middle group, and 60% of in the highest group. So the mortality of the patients again goes up depending on the level of cardiac troponin I. So this myocardial injury caused by COVID-19 affects patients' outcomes significantly. These are about acute phase injury of the heart. In addition to acute phase injury, long-term impact of the heart is also reported. This is a paper from Germany. They analyzed a cardiac MRI of 100 patients who recovered recently from COVID-19. In this study, they included patients who recovered at home. They included 67 patients who recovered at home. And the median age of this study was 49 years old. So the cohort of this study was a relatively mild cohort. Even in this mild cohort, they found that about nearly 80% of the patients had abnormalities in cardiac MRI, even after 2 weeks. And they also found that 60% of the patients had ongoing inflammation in the heart that can be detected by cardiac MRI. They also detected T1 or T2 changes even in home recovered patients, as you can see here. So the question is, what is the mechanism of this cardiac injury? One possibility is that this can be caused by direct infection of the virus in the heart. Another possibility is this is a secondary consequence of systemic inflammation or cytokine storm through endothelial damage or thromboembolic events. To think about the mechanism, I'd like to overview the basic molecular biology of this virus. This is the structure of SARS-CoV-2 virus. As you know, this virus has 4 structural proteins: spike protein, membrane protein, envelope protein, and nucleocapsid protein. And the genome of this virus is single-strand RNA. In their genome, they have these 4 structural proteins at the 3' site. And at the 5' site, they have non-structural proteins. For example, they have RNA-dependent RNA polymerase because their genome is RNA. So to replicate themselves, they need to make RNA from RNA in human cells, but human cells cannot make RNA from RNA. So they have these enzymes to maintain their system and to replicate themselves. Among these four structural proteins, spike protein has been paid the most attention in terms of research because spike protein is a target of vaccine development. And this is for the development of neutralizing antibody as well. And this is spike protein. Spike protein has two subunits, S1 and S2. S1 subunit is the outside of the spike. So this part is important for the binding to human cells. And S2 subunit is inside. S2 subunit is important for membrane fusion between viral particles and human cells. This slide shows how the virus infects human cells. This is a virus, and this is a receptor of the virus called S2 on human cell side. And there is another enzyme called TMPRSS2 or TMPRSS2. Once the virus binds to human cells, this gene, this enzyme can cut off S1 subunit, and S2 subunit is exposed to human cells, and S2 subunit promotes fusion of virus and human membranes. And then the viral RNA can go into human cells and they can replicate. In this process, the receptor S2 is one of the most important genes because this is the entry point of the virus. So if the human cells do not express this gene, this virus cannot infect the human cells. So how about the expression of this gene in the heart? As you can see here, human hearts express this gene. And the expression level of this gene in human heart is relatively high compared to other major organs, including brain, artery, kidney, liver, and lung. So in this figure, this expression level is even higher than the lung. And the heart consists of many cell types, including cardiomyocytes, endothelial cells, fibroblasts, and immune cells. And if you look at single cell level by single cell RNA sequencing data, as you can see here, cardiomyocytes express the receptor S2. But expression level is not very high. And the cell type that express S2 most abundantly is pericyte. Pericytes are a cell type that is surrounding endothelial cells in the vasculature. So at least we can say human hearts are expressing S2, the viral receptor gene. To study the mechanism of COVID-19, human stem cells are often used because this virus infects human cells, but this virus does not infect mouse or rat, which are the most common animal models in biological studies. So this is one example. In this study, they differentiated human stem cells to 8 cell types. And they found that cardiomyocytes are one of the cell types that can be infected by this virus. This is another example. In this study, they showed that human cardiomyocytes can be infected in vitro. They made iPS cell-derived cardiomyocytes and infected cardiomyocytes with this virus and showed that after infection, cardiac-related genes are dysregulated. This is one more example of bioarchive preprint. They infected human iPS cardiomyocytes, and they found that the sarcomere structure of cardiomyocytes was disrupted after infection and fragmented, as you can see here. So human cardiomyocytes express viral receptor, and in vitro experiment, cardiomyocytes can be infected. So how about actual patients? Does this virus really infect their heart in patients? This paper was published from Germany. They analyzed 39 autopsy cases. They found that about 60% of the patients had virus in the heart. They also found that 40% of the patients had high copy number of virus in the heart. And more than 10% of patients had evidence of viral replication in the heart. And the gene expression of inflammatory genes such as TNF-alpha or IL-6 were upregulated in these patients. So the virus exists in the heart, in patient heart. However, the same paper also reported that they did not see any patient who had infected cardiomyocytes. And they detected viral RNA only outside of cardiomyocytes, as you can see here. This study also analyzed immune cell infiltration to the heart. However, they did not see any difference between virus minus samples and high copy number virus samples. That means these immune cells are not coming to the heart to target infected cardiomyocytes or to remove infected cardiomyocytes. So the hypothesis of direct infection to cardiomyocytes leading to classical fulminant myocarditis is not likely to be the major cause of cardiac injury from this study. Although there are few case reports that suggest direct infection in patients, direct infection is not likely to be what is happening in the majority of the patients from this study. And this is another autopsy study. They analyzed heart samples from patients who had troponin I elevation and who died from COVID-19. Again, unexpectedly, they did not see infected cardiomyocytes. They found viral particles only outside of cardiomyocytes, again, as shown here. The same group also analyzed 21 autopsy cases, autopsy papers published this year about COVID-19. Among 277 cases, they found that myocarditis is there. Only one study contained about 50% of myocarditis, but when they looked at the detail, the definition of myocarditis was different between studies, and they concluded that the classical myocarditis can be seen only less than 2% of autopsy cases. Even though these autopsy cases are supposed to be severe COVID-19 cases. So the direct infection of virus would not be able to explain why 30% of the patients have cardiac troponin I elevation, or why 80% of patients show subclinical abnormalities in cardiac MRI. From these results, experimental in vitro data and clinical data are inconsistent. What we can say from these results is that direct infection is possible, but this is very rare. The more likely mechanism would be this is secondary. This is a secondary consequence of systemic inflammation or cytokine storm through endothelial damage or hypercoagulation caused by hyperactive inflammation. So the hypothesis that COVID-19 is a vascular disease would be able to explain why this disease causes so many multi-organ damages. In mild cases, the inflammation is limited to the heart, to the lungs. But on the other hand, the inflammation can spread from the lung to many other organs through immune cells and blood saturation. And cytokine storm can cause vascular injuries and hypercoagulation, leading to multi-organ damages, including stroke, myocardial infarction, kidney injury, liver injury, and so on. But what we still do not know here is that whether this is something specific to COVID-19 or not. Because most COVID-19 studies do not have control groups of other infectious diseases, such as influenza or bacterial pneumonia. So we don't know whether there is something exclusive to COVID-19 or not in this mechanism. In terms of therapeutic options, endothelial cells or endothelial functions can be a therapeutic target. For example, multiple studies show that statins may be able to reduce the mortality of COVID-19, as shown here. So these results are supporting the hypothesis that COVID-19 is a vascular disease. One more mechanism we need to think about is renin-angiotensin system, because the viral receptor ACE2 is a part of renin-angiotensin system. As you know, the main effector of renin-angiotensin system is angiotensin 2. Angiotensin 2 binds to its receptor and increases blood pressure. So this pathway is basically considered to be harmful in terms of developing cardiovascular diseases. And there is a gene called angiotensin converting enzyme. I would call this ACE1 here. This gene, this enzyme makes angiotensin 2 from angiotensin 1. So this gene is a target of hypertension treatment. On the other hand, the viral receptor ACE2 breaks down angiotensin 2. So this gene is considered to be protective in terms of cardiovascular disease development. And it is also known that when the virus infects human cells, the expression of this gene is downregulated. So the downregulation of ACE2 by SARS-CoV-2 infection may also enhance the progression of cardiovascular diseases as well. The knockout mouse of this gene was already reported almost 20 years ago. They reported that this knockout mouse has a phenotype of severe heart failure, as shown here. And it is also reported that this gene, ACE2, is involved in many cardiovascular diseases, including atherosclerosis. So the dysregulation of renin-angiotensin system may be able to explain a part of the mechanism why this disease causes so many cardiovascular problems. I'd like to summarize. COVID-19 causes diverse cardiovascular damages. The potential mechanisms are first, this can be a direct infection of this virus to the heart or vessels. And second, this can be caused by dysregulation of renin-angiotensin system. And probably more importantly, cardiovascular damage or other organ damages can be caused by vascular injuries through direct endothelial damage or hypercoagulation that can be caused by hyperactive immune response by COVID-19. With that, I'm happy to take any questions. Thank you for your attention.
For that wonderful presentation. We now enter our questions. Before we start, a quick reminder that during this session, you may submit your questions to our speakers using the Q&A tab at any time. Our first question will be for Dr. Connolly, and this is going to be a bit of a broad question because we have many audience members who are asking about potential causes for COVID-19 related neurocognitive disorders, and whether things like symptom severity, the hospital treatment that patients may have received, the presence of inflammation and the severity of inflammation, do factors like that have a relationship or a correlation with neurocognitive disorders, either in severity, or is there a type of neurocognitive disorder or symptom that's linked to a specific pathological symptom profile?
Is it? Oh,
It looks like at the moment Dr. Connolly might be having some technical challenges, so...
God almighty.
No,
Hello?
I think we can hear you.
Oh, can you?
Yes.
Okay. I'm glad I wasn't saying anything too offensive. So it's a very good question, and there is, as right now, long haul research is very new. So there is nothing too definitive, but the long list of other consequences, for example, intubation, variety of them. They could be factors. However, I think one of the issues with many long haulers is they've never gone through hospitalization. Some of them have never been formally diagnosed. They were certainly in the UK. There was a suspension of taking people into hospital because they were struggling to cope, and so some were sent home and told to isolate. So, and they never went back, and they were never formally diagnosed. But in retrospect, many of those patients are now being diagnosed as having, yes, indeed, suffered from COVID-19. So I think, because when we were first talking about designing work to look at some of these questions, exactly what the questioner has asked, we were talking about intubation, we were talking about general ICU, the use of different medications, sedation, steroids, if there was any inflammation, a range of those sorts of things. Some of those now are moot points because a lot of these patients, as a very differentiated and heterogeneous group, they really form their own control groups. Some of them are long haulers who did have all of those procedures done, and others have never had anything done, but they are judged now by physicians that are not entirely consumed with keeping people alive. They're looking at them and saying, yes, this is clearly, you did have COVID. So I think the answer is they may be confounding effects in terms of research. They may be confounding effects in terms of people's sensitivity to them. But over and above all of those factors, there is still a separate entity that is neurocognitive consequences due purely to the COVID virus. And in terms of profiles, we don't know that yet. Only time will tell. There's still a great deal we don't know about this.
Thank you, Dr. Connolly. Dr. Nishiga, I was wondering if there were any studies that looked at endothelial damage, directly looked at endothelial damage in COVID-19 patients, because many studies, especially from a clinical perspective, will look at measures of cardiac function, echocardiography, and troponin as a kind of assessment of overall heart function and cardiomyocyte damage. Has anyone looked at endothelial damage, possibly edema or circulatory disorders or anything like that?
That is a great question. Thank you for asking. I don't think people measure endothelial function in patients. I think, so, measuring troponin would be easy, but it's not easy to measure endothelial function in patients and in real COVID-19 patients. And so I don't have a good answer for that.
Thank you, Dr. Nishiga. Next question, also for you. Host inflammation is part of the body's response to most infectious diseases, bacteria, virus, parasites, etc., etc. A lot of those viruses don't have a cardiovascular component. What is so unique about the inflammatory response in SARS-CoV-2 where we are seeing targeting of the cardiovascular system? And did we see it as well in related coronaviruses like SARS-CoV-1 or MERS?
Yes, that is also a great question. So current COVID-19 studies do not compare COVID-19 and other viruses or other bacterial pneumonias. So we don't know what is specific to COVID-19. But from our experience this year, COVID-19 probably may cause cardiovascular damage more frequently than other infectious diseases, but we don't know the reason. I think for influenza, there is a paper in New England Journal maybe last year. After influenza infection, the myocardial infarction increased. So this might be also true other infectious diseases, but so there might be something specific to COVID-19, as you mentioned. So it can be caused by other viral genes or other response of human side, but we still do not know.
Thank you, Dr. Nishiga. Dr. Connolly, is there any relationship from the very publicized symptom, COVID-19 infection symptom of loss of taste, loss of smell, to other effects on the central nervous system?
That's an interesting question because at one point, early on, I think around last May, people were suggesting, papers were suggesting, and letters and correspondence, like in the New England Journal, were suggesting that that loss of taste and smell and headache, first of all, represented the possible entry points, symptoms of the entry points being the cranial nerves 1 and 5 into the brain. There's been some work to question that now, but nonetheless, they were suggesting it would be, it's so robust, those particular symptoms are so robust in at least the samples those people were saying that it could be used as a diagnostic. I think that it is still common, but I think to suggest it would be a diagnostic would be an overstatement. So it was coming along with, like the Sapienza study certainly talked about that you had headache, you had taste, smell loss, and the trouble is, and that is the problem, the profiles of many of these patients include a very long list of symptoms. And because there are patients that have absolutely unquestionably have COVID-19 and have very mild cases of respiratory problems, very mild, and yet they have significant other problems, which might be loss of taste and smell, etc., headache, and some of the other symptoms, but they will have very minor respiratory problems. So I'm afraid the coronavirus, I think, can be described as opportunistic. It will go after a system that it takes as vulnerable. I think one of the other issues is, for example, in the study about psychosis, the question of steroidal medicine being used, you need to understand that it is still not understood what the mechanisms are for all of these patients. We may find out that the symptoms are really related to quite different responses to presumably the same virus and not different strains of it, so that it might be an immune response to it, as opposed to a neuroinvasive response. So it is a very clouded picture regarding the symptomatology.
Thank you for that, Dr. Connolly. And also, what dictates whether a respiratory agent or respiratory infectious agent is neuroinvasive? And maybe more specifically related to what we're seeing with long haulers and COVID-19, what dictates whether a virus, once it does enter the brain, causes effects in a relatively rapid time course versus a infection that might be more latent, more dormant, and would manifest over the course of years or decades?
That is really an excellent question, and unfortunately one that leads to very worrying implications. So that I think trying to time things with entry into the brain is not known yet, and it really is quite complicated, because if we look back at other viruses like SARS and MERS, some of those patients have had symptoms or reported symptoms lasting 2 years. And in terms of remission, that also is a problem, because what is being seen both in MERS and SARS, which got less attention because far fewer people were affected by them, but what we're seeing certainly in coronavirus, and it also has been reported for, like I say, SARS and MERS, is that the symptoms will wax and wane, that a patient will feel that finally their ability to remember very simple things, again, it really can mimic dementia-like symptoms. When they find that's coming back, they think, oh, at least that is taken care of, and I'm recovering, and then they will, in a sense, relapse. The symptoms will come back. So the idea of has even been proposed that the idea, and I'm not a virus expert, so anybody out there should keep that in mind, but just what I've been reading is that it's been likened to viruses that stay within the body, stay within the host, and they will come back possibly. I don't know about very long-term SARS and MERS recurrence of symptoms, but I do know that those certainly some people had symptoms that went and came back over the course of at least a couple of years. So all of that is still very, very new. One has to sympathize with the vaccine people when people are asking them questions and they're saying, we just don't know that yet. So these are a lot of very good questions that we just don't have the data yet to answer it definitively about this virus, but we do know that some of these symptoms will recur, and it does sometimes. We know that from SARS and MERS, and we know that we don't know the causes of that, except that it's obviously still present, and it just has not gone away. It has been dormant.
You're saying that there's a viral reservoir still present that comes and goes and causes symptoms to wax and wane, or the waxing and waning is because of the damage that the virus initially did, but now that the virus is gone?
I don't know. Honestly, I don't know. I think the fact that it's recurring within several years would suggest that it's not due to any damage that the virus caused, as in SARS, that it might be a reservoir that's left, and that it can, in possibly undocumented other health issues, may recur due to a weakening of the immune system, for example, and it begins to come back again a little, the viral elements, the viral symptoms. It just is, it's, as far as I know, it is not clear yet which that is. Certainly not for COVID-19.
Thank you, Dr. Connolly. Dr. Nishiga, how similar is COVID-19 induced cardiovascular damage? How similar is that compared to, for example, myocardial infarction, cardiac damage? Do they have similar injury profiles, similar recovery profiles? or are they different entities?
Thank you for the question. I think that depends on the mechanism of cardiac injury. I think the cardiac injury caused by COVID-19 is combined, heterozygous. Probably some patients had a small myocardial infarction, but some patients may have cardiac damage caused by some factors secreted from lung cells or immune cells. So it depends on the mechanism of cardiac injury. So I think, so as I mentioned, probably cardiac damage in patients are caused by some kind of secondary consequence of systemic inflammation. And so cardiomyocytes can be damaged by those secret factors. And there are some reports of myocardial infarction in COVID-19 patients. In some reports, some patients did not have even fever or pneumonia when they had myocardial infarction, and they were admitted to hospital because of just chest pain without fever. So there is a possibility that COVID-19 can cause myocardial infarction even without pneumonia or fever. So SARS-CoV-2 may cause vascular injury directly without cytokine storm. So, but probably this is not the majority. So in the majority, I think the inflammation causes some factors and some mediators, and the mediator causes cardiac injury. So in those cases are different from regular myocardial infarction we see in clinic.
Now, you've just mentioned that cardiac symptoms might not be tied to respiratory symptoms. So then, does that mean that the medical system should screen asymptomatic or mild symptomatic COVID patients for potential cardiac damage?
Yes. Yes, but probably the percentage is pretty low. I think there are only case reports or case series that is showing myocardial infarction without pneumonia or without fever. But I don't think that is a majority of the patients who had cardiac injury. But this is still possible, I think.
And just as a last note for this series of questions, do you have any ideas on why statins might be protective?
I think those statin studies are basically retrospective studies and clinical studies. So in terms of mechanism, we don't know. As with other statin clinical studies, because statins always have pleiotropic effects, so many protective effects that is unknown, or that can improve many things. So in COVID-19, probably statins are working as anti-inflammatory drugs or vascular protective drugs, but probably we still do not know what is the precise mechanism.
Thank you, Dr. Nishiga. And to close our webinar today, I want to ask a question to the both of you, and this will be specific, of course, to your specific field. What would you recommend as the strategy for treatment and recovery for long haulers? And if we could start with Dr. Connolly, what would be the best way to treat COVID-19 long haulers showing neurological symptoms?
Yeah, this is a challenging question. I think in the first instance, I'll be curious to see, related to a previous question of yours, I would be curious to see whether there were any signs that the virus remained present, just dormant, in which case I think going after that would be valuable, although history tells us that may be a little bit difficult to determine and then to treat. I think in terms of some of the neurocognitive symptoms, as you ask, could possibly be standard rehabilitation. What I mean by that is cognitive rehabilitation, either done by neuropsychologists, people in allied health, occupational therapy, some physiotherapy, speech-language pathology. I think there's a range. There are so many different symptoms associated with COVID. Like language, many people feel should be listed as number one, even though our experience is that we have not seen very much of it, but we haven't seen very much of it at all to begin with. So making these separations, I think I would start with what's out there in terms of standard neurorehabilitation methods, and then start, as we learn more about the mechanisms of the virus and the effects it produces. In other words, is it immune response that's really kicking off the whole problem? An overreaction, as we know some of it is some of the brain injury or potential brain damage due to lack of oxygen going to the brain due to the pulmonary, the respiratory consequences? It is still a very much open-ended question, but I think the only thing to do is, until you understand those mechanisms, is to use those treatments that are currently available and work with at least traditional rehabilitation of things, frankly, like stroke and various other insults to the brain, just a traumatic brain injury and just acquired brain injury generally, and go from there.
Thank you, Dr. Connolly. Dr. Nishiga, similar question. Are there any treatment courses, potential use of exercise or other rehabilitation strategies, medications, so on and so forth, that you would recommend for treating COVID-related cardiac issues?
Yes, this is a tough question. So for long-term impact, we already have some data. We already have some studies already reported, as I showed about cardiac MRI. And some patients have more than half of patients have some kind of damage in the heart that is subclinical. They don't feel probably anything. So if you think about that, this disease may cause other long-term impact, because this disease is probably a vascular disease, and inflammation is playing important role in the disease mechanism. So the patient who experienced severe COVID-19 may have, may develop other cardiovascular diseases in the long term. So we just need to be careful of these patients for long-term outcomes. So the statins or other cardioprotective drugs or exercise may help, as you mentioned, but we just need to follow what is going to happen in the future.
Thank you, Dr. Nishiga. Unfortunately, that is all the time that we have for today. If you have any further questions, please consider reaching out to the speakers directly, and their email addresses are shown on the screen. As a reminder, this webinar will be archived on the scientist's website, and you will receive an email notifying you when the on-demand version becomes available for viewing. I would like to thank everyone who took the time to join us today, and particularly those of you who shared your questions and comments. On behalf of the scientist, I would like to thank our speakers, Dr. John Connolly and Dr. Masataka Nishiga, as well as our sponsor, Sinobiological. Thank you, everyone, and have a pleasant day.